They're preparing. I don't know if we're live. Okay, guys, we are live on Facebook at Alive Holistic Health Clinic today. We are so super thrilled to have you. And I have to tell you guys, before we even start, that it took something to get all four of us here. We're all dealing with life. Dr. Sharma, who we have as a guest here, was literally in the middle of 3 procedures. Okay. And then Nikki Logan, who will introduce both of them later, but Nikki was in ER herself last night. So and I have to go to emergency to see my mom after. But here's the thing. We are so dedicated to you and giving you valuable information that we are showing up and we're ready and we want to kick some butt and share everything that we need to know, that you need to know, so that you can have an informed choice in what you do in your life and for pregnancy. So here we go. Dr. Tanya Wild is with us. I'm not sure what you're contending with. I think you have your kids on PA day, whatever. Anyway, we are here and we're going to talk about prenatal testing and, do we do it? Is it wrong? Do you want to add something to that, Tanya?
The biggest thing is if you've gone through the fertility journey and you're super high stress, if the stress seems to not kind of go away, and is NIPT something you can use to kind of peel away some of that stress, knowing that, you have a low risk pregnancy, low risk for chromosomal issues? Or is it going to increase your stress because you then find out that you have a false positive? And we're going to talk all about what that means, false positive and false negatives, from Dr. Sharma and Nikki. Nikki is a genetic counselor at Create, and Dr. Sharma is a lovely endocrinologist working at Create. And she also founded the fertility blog, The Conception Diaries. So welcome to you both. Thank you so much for being here. We would love to just find out, what is NIPT, and will it reduce our stress if we get tested at 9 weeks and we're pregnant finally after a fertility journey? Tell us all about NIPT.
So I can start. When we talk about prenatal testing for patients, I always say we've come so far in reproductive medicine. We're able to micromanage the pregnancy you have, especially through the pregnancy clinic and the fertility clinic. And it's great, as you said, in that we get a lot of information, but with information also can come stress, and with lots of tests can come stress. But I find in my practice, patients really want to know everything they can about the pregnancy because it allows them a sense of control to know what they're dealing with. So when we talk about prenatal tests, once a woman is pregnant, whether it be after fertility treatment or after natural conception, the idea is that the pregnancy is either chromosomally normal or chromosomally abnormal. We know that as women get older, that they have more chromosomally abnormal eggs, and particularly in the fertility clinic, the majority of our population is of advanced reproductive age. So they're quite typically women over 35, and they have a higher risk of chromosomal errors, whether they get pregnant naturally or with assisted reproduction. And so when a woman gets pregnant and they have not used any genetic testing of their eggs or embryos through the process, there's always this question of, is this pregnancy normal or not? And so that's where prenatal testing comes in. And historically, prenatal testing didn't start until 12 weeks gestation, where you did a non-invasive test called the NT. It's an ultrasound measurement of the baby's neck, and it's got some sensitivity to predict chromosomal aneuploidy and things like Down syndrome, but it's only 70 to 80%. And oftentimes women, particularly older women, when they would do this test at 12 weeks, they would have an elevated risk, and then they would have to talk about amnio. Amnio doesn't happen until 18 weeks. They stay pregnant for a long time. They have to deal with the possibility of terminating a pregnancy. And as you said, that can elicit a lot of stress for the patient, a late trimester procedure that is psychologically and, medically just complicated and hard on a woman. And so
Absolutely.
We were really we in the fertility world and in the OBGYN world were ecstatic when the NIPT came out. And this is a blood test that's done early on in the first trimester, can be done as early as 9 weeks. And what it's looking for, it's a blood test. So the woman who's pregnant herself does a blood test. What it's looking for is fetal DNA. So DNA from the fetus that circulates into the maternal blood. And so by looking at that blood and that DNA, it's thought to be highly sensitive and specific, over 90% for chromosomal abnormalities. And so initially when this test came out, and I'll let Nikki speak a little bit more about this because she's certainly much more versed in this than I am. Initially, it was looking at mostly the 3 types of Down syndrome, trisomy 21, 18, and 13. And those are the things people worry about as they age. But it's sort of expanded to include a platform that can even test for all 23 chromosomes. Now, the beauty is that this blood test comes back relatively fast in 10 to 14 days. So you're still in that first trimester window. It didn't involve anything invasive like a needle going in. It's highly specific. And if it's a normal result, you're almost 99% sure that your baby is chromosomally normal. And so, yes, that takes the weight off the patients in terms of worrying about miscarriage due to genetic aneuploidy or having to wait a long time before they find out because of their age that they have, God forbid, a Down syndrome pregnancy. The opposite side is if the test is positive, particularly for the trisomies, it is pretty sensitive, and the likelihood that if you do not want to keep an abnormal pregnancy that you will want to go ahead with a termination. The good news is you can do that much earlier in the pregnancy than you would have been able to if you had did these later tests that have to have a shoring test done later on. And so a DNC or a termination can happen sort of around the 11 to 12 week, 11 to 13 week mark rather than the 16 to 18 week mark. So there are some pluses and minuses, but the reason actually this whole group came together was that with any test, there are false positives and false negatives. And the false positive risk is what worries patients, and it also worries doctors. And interestingly, there was an article that just came out recently in the New York Times highlighting that the NIPT can be fraught with false positives, especially and particularly for rare syndromes. And those aren't the Down syndromes, but gender abnormalities and something called microdeletions. And so what do you do when that happens? You know, it's anxiety for the patient, anxiety for the doctor. What do you do next? And so we're here to speak about that. But before we do that, I'm going to defer to Nikki Logan, our genetics counselor, who's absolutely fabulous. And I think I email like 10 times a day about genetic questions. And I'd like her to give her synopsis of the NIPT and the pros and cons, because she sees it from a different perspective, the genetics perspective. And I think that's highly valuable.
Absolutely. And before you do that, Nikki, we're so grateful that you're here, by the way. NIPT is actually standing for Non-Invasive Prenatal Testing. So yes, it is a blood test. Yes.
Thank you for explaining that. That's perfect.
Thank you, Dr. Sharma, for that introduction. And just like Mary had said, NIPT, the T stands for testing. But I would really like for us to change our terminology and change it to NIPS, S for screening. And that is a really important difference between these two. The reason being is that this is not a diagnostic test. This is a screening test. So like Dr. Sharma said, you're going to have false positives. We're going to have false negatives. We're going to give you a risk value that this pregnancy is affected by Down syndrome trisomy, which is trisomy 21 or trisomy 13, trisomy 18, or some of the other chromosomal abnormalities. It doesn't give us a diagnostic test result. So it doesn't say, yes, this baby has Down syndrome, or no, this baby does not have Down syndrome. However, when we are talking about Down syndrome, the positive predictive value of this test is very high. And so most times we can almost say that this is a diagnostic test, but there are some cases that will be false positives.
So can I just cut in for a second, Nikki?
Yeah.
So in terms of the testing, like now this is going back a couple of years, so I don't know if things have evolved for NIPT or NIPS. So because I was told at that time, it's like the testing for the screening for Downs was really accurate, but for the other chromosomal areas may not be as much. So can you speak to that while you're, going on?
Yeah, for sure. And that's still true. And the reason being is because the amount of pregnancies that have Down syndrome is much higher than those other chromosomal changes.
So what does that mean?
The prevalence of Down syndrome is a much higher than the prevalence of trisomy 13 and the prevalence of trisomy 18. And so when when these companies that do NIPS are figuring out the positive predictive value, one of the numbers that they have to take into account when they figure out the positive predictive value is what is the incidence of this condition in the population that we're testing for. And so, like Dr. Sharma said, in the infertility world, that population is typically older women, so women who are older than 35. However, every woman who is having a baby has a risk of having a baby with Down syndrome, regardless of their age. It's just that we see it more commonly in women older than 35, but even a 25-year-old who's having a baby has a risk of having a baby with Down syndrome. The reason scientifically being is that the chromosome 21 is the smallest of the chromosomes. So it's much easier for that chromosome to continue on and result in a pregnancy that lasts to 9 or 10 weeks, as opposed to chromosome 1, which is our largest chromosome, and that would just cause havoc in the growth of that embryo. That embryo is not going to last to week 9 or week 10. And so historically, the reason why we have always focused on Down syndrome, which is tri-21 or trisomy 13 or 18, those are the chromosomal changes that are viable at birth.
Sure. So then what happens when someone someone does an IVF, they do genetic testing. So they did the PGTA, and then they're considered normal. All these embryos are normal. And let's say they put that embryo in, that chromosomal normal embryo in, they're pregnant. Now, does that person choose, or should they choose to do an IPT?
Yeah, that's, it's a great question. And I'm going to comment from the clinical perspective, and then maybe Nicole, you can comment from the genetics perspective. I can tell you what we do at our center at Create. And I think what's almost universal, what I'm always told is, PGS genetic testing, or PGTA, where you take a sample of the cells in the blastocyst and test them. Remember, you're not sampling that whole blastocyst, which is composed of hundreds of cells. You're just taking 3 to 5 cells from the trophectoderm, which is the outer lining of the embryo, which actually forms the placenta. And that's a whole nother discussion. Some people think that there's a lot of mosaicism in the placenta and it might not be representative of the embryo. In any case, PGTA is still a great technique. And if you take and sample those cells, you don't damage the embryo and you get a clear picture of the chromosomal makeup. And you're right, if you transfer a normal embryo, it enhances the success rates. Patients who do frozen embryo transfers with PGTA embryos have a high pregnancy rate. And if they get pregnant and they go on to 10 weeks, okay, now what do I do? And so in our clinic, we do offer NIPS testing to our patients who do PGTA, because now you're sampling the whole fetus. So now you have this fetus that's producing DNA. And so it's actually a different screening test than those 3 to 5 cells. And so we do that to reassure ourselves and double check PGS testing. And this part I'll let Nicole comment on, but we're told by our geneticists that those rare chromosomal abnormalities, like the microdeletions, that perhaps because of the incidence or the prevalence, and I'll let Nicole explain, they are probably more well detected by the NIPS screening than the PGTA. PGTA is more designed for 23 chromosomes and may not be able to detect these small microdeletions, which are also prevalent in the population, in the general population. And so by doing NIPS, you might pick up something that was not picked up in PGTA. Now, I'll tell you, in my clinical practice, I've been doing this for 13 years. It has happened a couple of times where PGS normal embryos have come up with microdeletion positives in the NIPS screen or gender abnormalities in the NIPS screen. The majority of these thankfully end up to be normal babies, but have there been pickups with the NIPS where we actually find an abnormal baby that wasn't picked up by PGTA? We have. But the question remains, these small 1 in a million ones that you pick up, is it worth it? Is it worth doing all this screening? So I'll let Nicole comment, because it's actually a great question that I would love to learn more about too.
Right. And then also adding to it, because you were the one who contacted me, Dr. Sharma, about the New York Times article. So speak to that, because there was something that goes with this conversation.
Yeah, I mean, I think that New York Times article was really talking about cost benefit, risk benefit, because if you do, and I'll take this a step further, if you do show up with an abnormality in the sort of minor but prevalent, more rare abnormalities like the microdeletions, now you have this discrepancy. So you had a pregnancy that seemed normal by PGS, you have an abnormal NIPT. If you didn't do PGS, when you got pregnant naturally, you have this questionable abnormality. Well, now you're stuck in the same boat as if you had high risk from the non-specific test at 12 weeks. You have to, typically what happens is we send the patient for a high level anatomy scan with one of the high risk doctors. Are you okay? Okay, good. Just
Sorry,
making sure
I'm putting a mute because I was drinking my hot water and it was a little too hot and I went down the wrong chute.
I was hoping
So
I didn't make you cry.
Thank you so much. But I'm just choking a little from the water. I'm totally fine.
Okay, good.
So I'm going to mute myself for a second.
Okay, what I was going to say is now these patients have to get an anatomy scan, wait for a high risk consult, and then after the high risk consult, the high risk specialist decides if they will go on with CBS or amniocentesis. So this is a lot for the patient to go through, and then they have to wait and do their amniocentesis, and then some of these turn out to be false positives and some of these are perfectly normal babies. And I think that's what the New York Times article was highlighting, that perhaps are we over screening, and then patients just end up going through all of these tests, some of which are highly invasive, only to find out their baby is normal, which is a lot, especially for patients who are like, this is my magical pregnancy, my rainbow baby. And so it's a lot of stress on the patient. And so the question remains, what is actually data-driven and evidence-based? So I'll let Nicole speak to that.
Okay. So yeah, there's a lot of points there that I want to talk on as well. So we've been talking about the chromosomal changes of NIPS. So the 5 chromosomes mostly, so 13, 18, 21, and X and Y. Those ones are very highly, the positive predictive value is very good for those ones. 21 has the highest positive predictive value, followed by 18. 13 has a lower positive predictive value, but it also has a lower incidence in the population. X and Y are the sex chromosomes, and they are usually very good. But like Dr. Sharma mentioned, we can get that those can come back as inconclusive, and it usually is the number of those chromosomes. So there are genetic conditions in the population where you can have a female with 3 copies of X chromosome. Females are typically 2 X chromosomes, and males are X and Y. And you can have conditions where males have 2 X and 1 Y chromosomes. So those are our conditions that we can see in the population as well. And so we can pick up those conditions on NIPS as well. But again, those aren't diagnostic, and so we have to talk to patients about what those results mean.
That can be so confusing though, right? I mean, when a person sees all this, it's like, oh my gosh, what do I do? Do I terminate? Do I keep? Is it wrong? Is it right?
Yeah, sure. And I would never suggest to a patient to terminate based on these results. I would always suggest, the way I counsel the patients are, what would you do with this information if it's true? So if these results are accurate, how would that change the outcome of this pregnancy for you? And if it wouldn't change the outcome of the pregnancy, well, then maybe doing invasive testing is not something you need to do. Because then if it's not going to change the outcome of the pregnancy for you, then you may not need to know at this stage of the pregnancy. Maybe wait till later on in the pregnancy, or wait until birth and confirm those results. But if it would change the outcome of the pregnancy, then maybe doing invasive testing is something that you would want to do. So along those lines. But what the New York Times article was talking about was more about these microdeletions in these specific genetic diseases. So 22q deletion syndrome, Prader-Willi-Engelmann syndrome, Cree-de-Shaw. I think there's 2 others that have escaped me right now. But all of those have a much lower incidence in the population than something like Down syndrome. So Down syndrome, we can say, has an incidence of between, for most of these women, between like 1 in 200 to 1 in 1,000 or so. Whereas Prader-Willi-Engelmann, we're talking more like closer to 1 in 30,000 to 1 in 50,000. So those, we need to cast a much larger net of patients in order to find one positive case. So those cases, that's what the New York Times article was talking about. What Dr. Sharma was talking about, and Mary, along terms of your question about, do we offer these tests to couples who have had an PGTA normal embryo transferred? There are two parts to that. PGTA is also a screening test, just like Dr. Sharma said. We are only removing a small part of the embryo. We know that those results are 98% accurate, but that means that there's 2% of the time that they're going to be not accurate. So this is another way to look for that. These microdeletion syndromes that these NIPS that are looking at, they're too small to be looked at on PGTA. So PGTA doesn't even look at those because the changes are too small to be detected by the technology that we use for PGTA. So the way I like to describe it to our patients is, if you think of our chromosomes, we have 23 pairs of them. If we think of our chromosomes as a set of books, we look to make sure all the books are present. We make sure all the chapters are present, so big chunks of information. The microdeletions are the pages. PGTA doesn't look for the pages because that's too small of information. And then the information on those pages are the genes. And none of this is looking at the genes because that's just too much detail based on this information. So it's just the level of accurate, or the size of the changes that we can look at based on this information.
I love that
I love that analogy too. I'm going to use that. You
Yes.
patent that, Nikki. I'm going to use it now.
Yeah, we're all going to use it. Is that okay?
Amazing. Yeah.
I'm glad. In terms of what the New York Times article is saying and what Dr. Sharma had suggested about, should we be offering these tests because of the amount of false positives that are associated with them? I think that's something that we have to, this testing technology is available. And so there are some patients who want to know as much information as possible. And so for me, I think it's important to offer that to the patients, but letting them know that there is a possibility, there's a very high possibility that it's going to come back, showing that it's negative, that your child does not have any of these conditions. That if it comes back positive, that's going to be a false positive. But right now, based on our technology, this is the only way for us to know, in a non-invasive way, to know that this is a way for us to get this information.
Okay, so let's be really, really crazy, super practical. So it's a blood test. And I just occurred to me that I'm like, I don't even know how people are visualizing this blood test. It's like, is it through the abdomen, or the arm? Like, can you just give us like bare bones basics?
Yeah, and I can start. It is a blood test. It's only one vial of blood. So that makes it very practical, and patients feel very comfortable with that, especially after they've gone through fertility treatment, probably 1,000 million blood draws. So it's just one blood test. It's done at 10 weeks. And Mary, you ask a very good question, because in patients' minds, when they think of prenatal testing, they think amniocentesis. Like, that's what's in the media, right? And that's what they've heard about. With my 40-plus-year-old population, from the first consult, they're like, do I need to do an amnio? Because that's in their minds already. So we've come so far from that. I tell patients now, almost nobody does an amnio because we have all these great non-invasive tests. So yes, it is a blood test. Pros are, it's a blood test. It can be done early on in the pregnancy, first trimester. The cost, it used to be a couple of years ago, you had to pay $800. Now, many companies have come in, and just like any good business, there's a lot of competition. And so prices have been driven down. And so you can do sort of the bare minimum non-invasive prenatal screening for the 3 types of Down syndrome, gender, and microdeletions for around $200. And so that's much lower. I mean, I'll let Nikki speak to, there's sort of, and I always tell patients, there's the Chanel of NIPS that tests all 23 chromosomes. And then there's the, regular brand, or, what should I say, the winner's brand, that's the 3 Down syndromes and gender and microdeletions. And I think I go back to what Nicole said, and this spans to all of the testing that we now have available in reproductive medicine. There's so many en vogue new tests. I mean, we could have many of these webinars talking about ERA and all these other new novel things. And I think it all comes down to the doctor-patient relationship, having effective people like Nicole, the genetics counselors and whatnot. Good counseling is key. I think you need to tell the patients about the risks and benefits, the pros and cons, the false positive and false negative rate, and just help them make an educated choice. And that's what we're here for today as well. But yes, it's a blood test. Yes, it's about $200. Yes, it's done early in the first trimester. And good counseling is key.
Isn't it free? Well, okay, now we're talking about
Ontario.
Yeah.
Is it free for older women?
Yeah.
Yes.
Thank you.
So if you're over 40 and the eggs that you used for treatment, whether it was IVF or, your own eggs and insemination or natural, for women over 40, they do get it funded by the Ontario government. But if they want to add on these microdeletions, which are the rare disorders, they do have to pay an additional, part of the Chanel, because this is just the microdeletions, they have to pay an additional $200. And so I actually think we should stop and let Nicole explain, because now there's all these different variations of NIPS. There's the basic, that's the Down syndrome and gender. There's the plus microdeletions, and then there's the all 23 chromosomes. And this is where my knowledge is also not as good as Nicole's. There's various platforms for NIPS, so different ways of looking at the DNA, and that might be a little too specific for our audience, but I think it's worthwhile knowing about the different variations in NIPS testing and maybe who should use each one. Personally, as a fertility doctor, I talk about all the different versions to patients. Like everyone has been saying on this webinar, some patients are just, they want to be in control. They say, even if I've done PGS, I want the 23 chromosomes. Even if I risk a false positive, I want to see that report that says all 23 of my chromosomes are normal. And, I talk to them about the cost and they still go ahead. But I find the majority of patients will do the standard NIPS testing, which is the 3 Downs, the gender and microdeletions. And it's interesting, just a little tidbit about patients, they're most concerned about the gender. They want to know the gender of the baby. And so they like the fact that in 2 weeks, they'll know what the gender is.
Okay, that's funny. So it's funny that you say this like that, because again, I guess maybe our population of patients are slightly different. So, some of the patients that I deal with, they're like, oh, I don't know if I want to do the more testing if it's not going to be, as accurate, right? Like, do the basic. Anyway, I'd love to hear what Nikki has to say.
So there are many different ways to do this test and many different companies. You can go through and different cost points. So you can go through a Canadian company who actually will send it to an American lab to do it, but then it's in Canadian dollars, or you can send it. There are many, and then you can send it to a European lab to do the 23 chromosomes. The test that has the most accuracy is that basic test that does the 5 chromosomes. So the 13, 18, 21, X and Y, that one has the most accuracy because those are the ones that have the highest incidence. And that one is the basic test. So once you start adding things on, yes, you can get more information, but then the false positives and the positive predictive value, the false positives increase, the positive predictive value decreases. So if you're doing those microdeletion syndromes, they have a very high false positives, just like the New York Times article said. I don't quite agree with how they framed it in that article, but what they said was correct. But yes, it's those false positives are correct, but the positive predictive value is quite low for those tests. Once you get to do the 23 full chromosomes, I don't fully see why. I don't. If someone were asking me to do those, I don't advocate for those very often. Those ones have much lower accuracy to do those. If you're getting to 9 and 10 weeks of pregnancy, the risk of having a healthy pregnancy at that stage and having a chromosomal abnormality is low. The chance that you're going to have a trisomy or a monosomy, a loss of one of those other chromosomes is quite low at that stage. So I would think that you're not going to gain a lot of information by that stage. So yes, I would talk to the patient more about what their rationale or what their goal is for doing those that larger panel of testing. But yes, they are available, and if there are patients who want to know that information, we can offer that to them.
So I just want to cut in again, because I really want to thank you for alluding to that. It's like, yes, if you want to test, the basic one is very accurate, and just know that the other one's low accuracy. So it's like, why do you want to do it? Right.
Yeah, I think that's great. And I want to comment, I just want to rephrase what Nicole said from the clinical perspective for the audience. I think, and correct me if I'm wrong, what she's saying is most patients who have an abnormality in any of the chromosomes outside of the 5, the ones with the highest accuracy, they're either going to not implant, have an early biochemical pregnancy, or an early miscarriage way before that 10-week mark. So if they made it to that 10-week mark, you're really looking for the big 5. And so the value in paying $600 more, you're really not getting much more out of that test. And you might find out something that's not actually true and subject yourself and your pregnancy to more invasive testing and more stress for you.
Exactly.
So thank you for that, Nicole.
Nikki, can you clarify what would be the advantages then at that point? Let's say now that we have NIPS and let's say PGTA healthy embryos, and we've done all that screening, everything's low risk, of then going through the 16 or the 12-week and the 16-week, ultrasound for the nuchal translucency, like the NT and the, doing the further blood tests. Is there any advantage to then doing that later on in pregnancy?
Yeah, definitely. Especially the nuchal translucency. I would always say to continue doing the nuchal translucency if it's available to you, because that fluid at the back of the baby's neck is a marker for Down syndrome, definitely, like Dr. Sharma said, but it's also a marker for other things that may be wrong in the baby. So it may be a sign of a cardiac abnormality. It may be a sign of problems with the kidneys where the fluid isn't moving through the baby as it should, and it's starting to build up at the back of the baby's neck. So it's what we call a soft marker for a bunch of different problems that could be happening in the baby. It started off as being a test for Down syndrome, but now we have learned that it can make us make us look for other things as well. So I would definitely continue with the nuchal translucency at 12 weeks, even if you've done an NIPT and it has come back normal. But the other prenatal screening tests at 12 weeks would, like the integrated prenatal screen or the first trimester screen, those aren't as necessary. At 16 weeks, they do a blood test that looks for the alpha fetoprotein, which is not tested for on any of these tests. And that's a test that looks at the closure of the baby's spine for nuchal neural tube defects. So it's looking for a protein in the baby that is now circulating in mom's blood and can give us a hint as to that maybe there's something wrong with the spine. So all these other tests may be beneficial to continue to do for other reasons, not just for the chromosomal abnormalities.
So we can relax after 16 weeks.
Well, I also want to add a point here that I think with all of this genetic testing, both during IVF and with genetic screening of embryos and the NIPS, I think the other sort of flip side of the coin is that, I think patients and doctors breathe a sigh of relief when we get back those normal NTs and NIPSs. But, unfortunately, it's like the pregnancy is not over until the baby comes out healthy. And there are, unfortunately, a lot of things that can happen anatomically and mechanically with the baby that are not related to genetics. And so, while we do breathe a sigh of relief, I think it's important to tell patients that, you could have a heart defect in the baby or something going on with the kidneys that will be picked up at the anatomy scan at 18 to 20 weeks. And that isn't necessarily something that could be related to genetics. And so these are all sort of pieces of the puzzle when we're evaluating a pregnancy in the 39, 40 weeks. And so, yes, genetics is a huge part, but it's not the end all be all.
Every pregnancy has a 3 to 4% chance of having a baby with some type of physical or developmental difference. And chromosomes and genetics are only a small part of that change. And so it's important that all couples, all pregnant women know that even if they do these tests and they come back normal, that doesn't alleviate that 3% risk.
So then let's highlight, okay, so listen, science is all about looking for pathologies, which is really helpful and crucial in terms of like long-term decision making, but we have to actually highlight then the 97% piece, right? Because think about the mindset of these women. They're like highly sensitive, overly stressed anyway. So my preference is that they're not going to be focusing on that 3% of what the heck is going to go wrong versus let's celebrate the wins in this moment right now so that I can breathe and live a life, because some of these women are so over the top, they can barely function, right? Like literally some, I don't know if you realize, but some of these women like are taking time off from work because they're so stressed.
Absolutely. And you bring up a very good point. Like what I tell my patients, because, you know, we do, believe it or not, have women over 40 who get pregnant naturally, and they come in and you're absolutely right. They're on pins and needles until that NIPS. And they're like, oh my God, Dr. Sharma, I was worrying every day until you called me. But what I say to them is, you know, at 40 plus, probably, and Nicole can comment, it's probably like 1 in 100 risk of Down syndrome, but 99 out of 100 women over 40 who make it to 12 weeks will have normal pregnancies. It's that 1 in 100, which is elevated compared to the under 35-year-old population, but 99 out of 100 will still be fine. And so,
love it.
You know, it is important to highlight the wins. It's important to use the data for effective counseling. So I couldn't agree with you more.
Yeah. Mary, sure. did you do NIPS with your babe?
With my babe, no. I went to the anti-scan, obviously all the ones that are prerequisite standards. Yeah.
Which is really funny because I did too. And contrary to what Nicole is saying, I wanted the Chanel. I did the all 23 chromosomes. So it really just goes to show, even right here in this group of people, like every patient has a different value placed on that control of knowing data. And for me, I'm like, give me every single piece of data you can give me. So for me, like I knew the gender before my kids and all that, but everybody's different.
That's really
I didn't.
Great.
I skipped right over NIPS and I went right to amnio. I was like, I need to know. I need to know everything. So.
You're like, I want the gold standard.
Oh my gosh. So it is so interesting, right? I was over 40 and thinking like, you know what? I've had so much testing and so much procedural stuff. I'm like, I just need to breathe. I just need to like live my life and do the necessary ones, because otherwise, I don't know about you guys, but literally like you can breathe for a minute, like you have like, yay, negative testing, but then you worry about the next one, right? So even like the early beta testing, like every other day for like 5 times, that's 10 days. And like you get one test, your number looks good. And then you celebrate for like 1 second, and then you worry about the next beta level.
I feel like it lasted, and it was just something to constantly look forward to. So the NIPS, and then the screens, you know, at 12 weeks, and then the anatomy scan, and like every step along the way, I was like, phew, like it was just one more step.
4 different women,
I know.
No, but 4 different women kind of looked at it in 4 different ways, right?
Yeah, so, love it. Yeah.
And so that's why it's so important to have those conversations and just give people the option, because it's there now and it's empowering to have the options depending on the type of woman and what she needs.
Yeah. So the bottom line here is that, listen, we are totally arming you with a heck of a lot of information here, some of which you're like going shoo over your head, but it doesn't matter. You know, we're like, you can discuss with any one of us here, or don't just go down the Google rabbit hole of like misinformation and overwhelming information at that, and bad stories, like bad personal stories. And so get the information and decide what works for you. As Dr. Sharma put it here, we're just like a sample size of 4, and we're all dealing with it in different ways when we went through our pregnancy. So you do what works best for you. Anything else to add, ladies?
I
before
think
we-
we're just so grateful to have you here to give us the details, because there are a lot that I learned, and there's so much that I didn't know, to be honest. And if I don't know it, my patients don't know it. And I think information is golden. So thank you so much for being here to share. And we will have the show notes with the details so that people can process it, hear it again, watch it again, and then also have the written down. And super appreciate that you came today after being in the emergency room last night with, pain, and Dr. Sharma doing procedures and hopping in, and Mary, now you're going off to the emergency for your mom. And so
Yeah.
life
This is life,
happens,
right?
but we
Yeah.
showed up. So we are so grateful. Thank you
Yeah.
so much.
And the
for
show
having
notes
us.
that we're referring to is in our My Fertility podcast. So for those that are watching live, you can totally go back to when we released this as a podcast on My Fertility. Check out our website. It's brand new. It's like freaking phenomenal, if I may say so myself. And it's myfertility.com. And it's really about helping you thrive and, again, make informed choice, where we help boost you from preconception, during pregnancy, to postpartum, to perimenopause, menopause. So there we
Full
go.
circle.
Yes.
Great.
All right. So we'll end
I-
that. Thank you, guys.
Thank you. And, this is live, but it's going to get to, I'm going to stop the streaming right now. Bye, everyone live.